Welcome to the Ortho Joe Show, a joint production of the Journal of Bone and Joint Surgery and Ortho Evidence. In our world, orthopedic research is king, and current topics from our respective publications are analyzed weekly. Here is Mohit Bhandari from Ortho Evidence and Mark Swinkowski from the Journal of Bone and Joint Surgery.
Well, good morning, Mo.
Morning. How are you?
I'm sore.
Sore? Why are you sore?
We had some serious snow that actually prevented me getting back from the journal office back here to Minneapolis for a day. And when I got back yesterday about noon, I had 3 hours of shoveling. Looked like about 14 inches of moderately heavy snow. So I got a bit of a sore back. And I went back to the original mug.
Wow!
Because it's more volume in the mug than the white one. So,
but help me understand this. My 1 year with you in Minnesota suggested that Minnesotans are pretty strong, tough. They can take any sort of whatever winter will throw at you, they can take. So how is it possible that there's a storm that is shut down airports in Minnesota?
I don't understand it. There actually is an article on the front page of the Star Tribune this morning. I haven't had a chance to read, but the headline is, "Did we overreact?"
Oh,
and I think they did. But anyway, my back is sore, so I got to have more Joe. But I'm looking forward to our chat this morning because I want to talk about something that you've done a lot of your life at McMaster, your training and your doctoral degree, and certainly being on the staff and major leadership roles. And I want to look back on a project that we started. Boy, I want to say 2005 or 6 with Brian Haynes.
right.
There at Mac.
Right.
And the issue thing that we did at JBJS is when Jim Heckman was the editor, we created an article type of evidence-based orthopedics. And Jim Wright, your colleague from Toronto, was heavily involved. He and I actually wrote the editorial, the introducing levels of evidence to the orthopedic world in 2003. But anyway, I want to ask you about Brian Haynes and really what he was up to at Mac, and then I'll go on to discuss how we've used this in JBJS.
Absolutely. So I was around. I'll frame it with the term evidence-based medicine was coined, at least when we look back at the quote archives, by a small group. But Gordon Guyatt was at that time the program director of the internal medicine residency training program. And so they were coming up, him, David Sackett, Brian Haynes. This was this core group of individuals at McMaster. There are numerous others, but those are the key individuals that were sort of brainstorming a new way to be thinking, a new way to be teaching. So around 1990, so roughly 1990 is when they coined it.
Okay.
94, 95, I got to McMaster doing an orthopedic residency training program. And it was probably 96 where I met, 95, 96 where I met Gordon Guyatt and Brian Haynes at that time. They're all part of this group there that was doing this, research. Brian Haynes, for those who don't know, was involved with, if you've ever done a PubMed search and you've typed in the word, sort of the randomized trial filter, he's the one that worked very carefully on working with National Libraries of Medicine and PubMed in creating these filters. So a lot of the algorithms to identify evidence comes from Brian Haynes. In fact, he had done lots of the pre-appraised evidence reviews. So he had multiple journals. Something called ACP Journal Club was one of the big ones that basically did what we've been trying to do at Ortho Evidence for some years, which is take evidence and coin it and summarize it in a way that makes it easy to digest. So his whole career and his pathway was really, how do we disseminate through knowledge translation evidence? Gordon's was a lot of education and knowledge translation, Gordon Guyatt, but a ton of his stuff was also related to the generation, sort of the conduct of surgical trials was around 96 really for him. Yeah. I mean, I think orthopedics was his first foray into large clinical trials with respect to surgery. He'd been doing lots of things.
Right. Yeah. So around the time that we began to understand levels of evidence at the journal, Jim suggested that we contact Brian, and he had developed this process of screening the world's literature for trials, basically, and then sending them around electronically to experts who would basically grade the trials in terms of levels of importance to the field. Is it information that's already known, or is this new? And then categorizing that as to how widely to broadcast the information in the trials. And of course, there were trials being published in musculoskeletal medicine and surgery. And what we agreed to do, Jim Heckman agreed to do, was to take a pool of the trials that were graded in orthopedic surgery and musculoskeletal medicine, and then send them to a deputy editor who would select the 3 on a quarterly basis that were the most influential, or that had the potential to influence the field. Initially, that was done by Jim, but most recently has been done by Bob Marks from HSS, done a great job with this. And we are now transitioning to my colleague who is at the Kaiser Permanente group. And Ron is going to be taking over this job and is just now dipping his toe into it. So anyway, what brought this up in going back into history, because I've known you for a long time and knew that you were at Mac, was I was looking at the most recent journal, and I saw the 3 that we selected. There's a selection on patients with non-acute ACL deficiency and instability, and that the long-term outcomes of ACL reconstructive surgery improve pain and function more than physiotherapy at 18 months. That's from Lancet. The second one is exercise-based physical therapy was not inferior to arthroscopic partial meniscectomy for knee function over 5 years in adults with degenerative meniscal tears, and that's in JAMA. And then the third one is in total shoulder arthroplasty, preoperative washes with benzoyl peroxide with or without clindamycin reduce skin Cutibacterium acnes colonization compared with Physohex before skin preparation and draping, but not during surgery. And that's from the Journal of Shoulder and Elbow Surgery. So 3 kind of disparate topics, but I think all have the potential for influencing care decision making. So you've published a lot. I've said before on this that I've seen your CV a few years ago, and you were in the 1,200 citations, not in minor journals. What causes you to think about publishing in Lancet, say, for example, compared to an orthopedic journal?
No, that's a great point. Well, I mean, I'll give you context to this. When we did and it came from a lot of it just came from education and understanding audiences. But when we did the sprint trial some years back now, it was by probably 2007 when we closed it out, 2008 when it got published in the Journal of Bone and Joint Surgery. In all full disclosure, as a steering committee, having done a large trial of over 1,000 patients, we were particularly keen to send it to some of the top medical journals because we thought of the scope and the impact. It ended up in JBJS, probably appropriately so, because the journals were saying, this is such an important topic that's very, very relevant to the practice of an orthopedic surgeon. And, they weren't necessarily sure how reamed or non-reamed tibial nailing, for example, would be relevant to, let's say, an internist or primary care. Now, how it got things changing was, okay, well, when there's been a large multinational effort on some of the trials we've done, I've always asked myself, and I'll use, let's say, the FLOW trial that was published in the New England Journal of Medicine mid 2000, like 2010, 15, or something like that, right? So that one, when we sat down in the steering committee, we said, okay, well, who would genuinely be like, who would find these results generalizable to their practice? And clearly, orthopedic surgeons would found it because it was an open wound irrigation trial, but it became very apparent that primary care folks who were managing wounds in all over the world would find this relevant. Internists would find this relevant. There would be potential plastic surgery would find this relevant. So we started seeing the scope get much, much bigger than orthopedics. And so we made that decision to say, okay, let's find a journal that has an audience that would cover all these multidisciplinary potential groups. And that led to some of our decision making. But if you look at the stuff that's happening now, we're starting to see more and more core orthopedic publications published outside of core orthopedic journals, whether it's a good thing or a bad. I mean, I presume that overall it's good for orthopedics, and that we're getting the message out that orthopedics has value. But you'll typically see, for example, Mark, New England Journal and some of these other journals. I'm editorializing this, so this has no bearing on what others might think about it. But generally speaking, if there is a major practice change effort, like, for example, surgery may not be as effective as non-operative treatment, that is almost preferentially what we've seen being published in the New England Journal. They rarely publish surgery is better, unless it's, I think they did one study of, total knee arthroplasty against physiotherapy, for example, suggesting total knee arthroplasty was better. But, something that most surgeons have known for decades anyway. But anyways, that was kind of the thinking around that.
Yeah, so it's really a question of the breadth of the audience, right? I mean, and that's why those journals, Lancet, JAMA, et cetera, have impact factors are in the 30s or higher, compared to us at JBJS, which are 7 to 8 range. It's because of the breadth of individuals interested in what they're publishing. So that was the thinking that Jim Heckman had in discussing things with Jim Wright and myself, that there are these articles that are published in other journals that are not typically seen by the orthopedic community. So that was the whole impetus behind this evidence-based orthopedic section. And so the way it works is, I know that Brian Haynes is no longer leading the group that is producing the information, but the MAC group sends to us and to our the newest editor of evidence-based orthopedics, Ron Navarro from Kaiser, the list of the high-level evidence that's been published in other journals, and Ron uses a process of going through them and deciding which ones are the highest relevance to us in orthopedic surgery to publish in JBJS, and we do it 4 times a year, generally 3 articles. Sometimes it's less, but I think it's been a very, very valuable addition to what we publish at the journal.
Well, and I'll tell you, it's like just from the practical point of view, this for sure, and I still remember this, that there would be situations where you would say that you would hold a journal club, let's say for trainees, and you would say, we will look at a single journal, and typically it was the Journal of Bone and Joint Surgery. It very rapidly, with information and the world that is now information based, became impossible for the journal to publish every possible existing high quality paper. You just can't do it, right? So there has to still be a place, and I think moving to this approach, exactly the reason and rationale for ortho evidence in my mind, which is how do you find a place where people can go to where they aren't missing the really good, important things? And so just because someone doesn't publish in the journal, well, doesn't mean that it wouldn't potentially be important. And I think it's a really important action to say, okay, well, let's bring that here. So, the loyal readers of the Journal of Bone and Joint Surgery are still getting important information that may not otherwise have been published in the journal, but still, in a clear summary format. I think that's the way of the future, right? We're going to have to find more pre-appraised resources, and we're going to have to find ways to cull it all and bring it into a single platform so people can actually digest it. It's too much information otherwise.
Right. And to be clear for the audience, we're very selective in the ones we publish at JBJS, but you at Ortho Evidence are trying to be comprehensive and really collect all of the level 1 evidence on individual topics, and have made great inroads there. What's the number of studies now in your database?
We're about 10,000 randomized clinical trials. Now, initially it was like, well, you'll never get even randomized trials don't exist for orthopedics, so they're not, the usual stuff. They're small. How do you trust them? And now it's at a point where we have to find ways to summarize a database of randomized trials because there's just so much information. And again, no reasonable person, unless they're spending all their time on the site, could consume it all. You just couldn't do it. So then we have to think about, okay, well, what's the next generation, beyond a summary? How do we get it? And maybe, as you've been hearing about things like Chat GPT-3, and if you haven't, it's worth us having a chat about that next time. But AI and machine learning and algorithms are becoming extremely prevalent. And maybe we have to be thinking more clearly and quickly about question answer types of things. Right? If someone has a question, they get the answer.
Right.
And I know you've spoken a lot about this, about point of care tools and the future development of those kind of tools. But I think that's where we're going to have to all head and use our information and data collectively.
Yeah. Well, we'll put that Chat GPT topic on for the next time we get together.
Absolutely.
In the meantime, I hope you've got your cup nearby.
Always.
And I'm actually going to add a couple of ibuprofen. So
I wish you all the best, and I hope your back gets back ready for golf season, by the way, and we'll have to talk about that. You have to help my game, I'll tell you that. So anyways, that's another story.
Looking forward to it. Well,
Right.
Thanks, Mo.
Right.
Talk
Take
to you
care.
next time.
You take care. Have a good day.
Bye.